CCR on behalf of the Department of Psychiatry. tDCS is trans-cranial direct current stimulation. We have very many new ways of stimulating the brain, elevating the brain. This is age of modulation, and I request Rohit to introduce the method and also present cases around.
Everyone, the science is progressing fast and so should we all be. But before going ahead, let's start from the beginning itself. Melancholia, the term itself was introduced by Hippocrates, none of them all. And in today's time, it's known in literally many terminologies, from lay literature to scientific terminologies such as depression or blues or sorrow or so forth. But when one says melancholia, it primarily indicates a biological form of depression, which is more inherited into the biological senses. In today's time, the World Health Organization estimates the prevalence of depression to be around 5% worldwide, while our national estimates are about somewhere around 4% in India. And what do we have to manage this deleterious entity? We have three things. One is psychotherapy, second is medications, and third is machines. Machines, which is also called as a somatic treatment strategies to manage psychiatric indications. Before leading further, just a small basic concept. The brain is composed of neurons, and as science has progressed, we understand that the neurons conduce neural impulses in form of not just chemicals, but also in form of ions. And these ions and chemicals together formulate what is called as the electrochemical conductivity in the neurons. So the electricity in form of ions traverses to the entire length of the axon, and at the end terminal bulb, the neurotransmitters are released due to a cascade of pathways which is shed by the electricity traversing in the neuron, which leads to the chemicals going to the opposite end of the neuron, to the postsynaptic terminal, and that is will bring forth the change from one neuron to the other neuron, and that chemical change again forces the electricity to pass away in the second neuron too. And that is what makes things work in a neuron. So in that sense, when we talk about medications, we are talking about the chemical side of the neuronal architecture change. And when we are talking about neuromodulation or brain stimulation, we are talking about the modulating the electrical side of the neurons. So this is what has led to a development of a newer, ushering of a newer era in psychiatry to some extent, from not just neuropsychopharmacology looking at the neurotransmitters in brain, but to neuromodulation, which looks more towards the circuitry-based neurotherapeutics of the brain. And that is what I am presenting today. So there are variety of brain imaging modalities present today, which tells us about the functional neuroanatomy of an individual. These are in form of functional imaging like fMRI, DTI, MRS, optical imaging, electrical imaging, and molecular imaging. None of them are individual specific. You cannot diagnose someone just by doing an imaging, but at a group level, they give you a consistent amount of findings to say that a patient with depression would have certain amount of change happening into his brain. And what we have found in the consistent cohort of group of individuals suffering from depression is there is a relative hypofrontality, which is particularly toward the dominant side of the DLPFC and the ventromedial or ventrolateral prefrontal cortex, which traverses to the deeper cortical areas of the limbic system. And this neurocircuitry is what gets altered, consistently seen in group studies of patients suffering from depression. And this is where all the neuromodulation varieties which are available as of now in today's time act upon. And they vary in their focality, they vary in their invasiveness, and they vary in their property of causing or not causing convergence. So today we will be talking about tDCS, which is a transcranial direct current stimulation system, which is one of the most non-focal, which is one of the most least invasive among all the neuromodulation possibilities which are existing in psychiatric sciences today. Literally speaking, it is just a very simple instrument mostly in form of a mobile kind of a size shape. It does simply delivers current, a direct kind of a current for 1 to 2 milliamperes of amplitude, and through two electrode systems, it is connected to the head, and where it stimulates the brain. The patient fortunately remains conscious all throughout this whole entire procedure. Nomenclature wise, we all know anode is a positively charged electrode, cathode is a negatively charged electrode. In electrodes, when we say electrode, it's a conductive rubber or metal plate which is separated from the skin by either a sponge, which is saline soaked, or some kind of a paste there. In electrochemistry, there are two different terminologies for electrolytes and electrodes. But in tDCS, the entire assembly is called as an electrode. So these electrode systems are, when kept over the head, they can be in two formulations, either a bipolar or a unipolar format. A bipolar format, when you keep both the cathode and the anode over the head, and a unipolar format, when only one of the electrode is over the head and the other is in an extracephalic position, most commonly deltoid. So what happens usually is, when we say that we are keeping an electrode over at the head, the cortical neurons, which are arranged linearly over in there, they get stimulated by that. And when you have an anode over at that place, the apical dendrites will get hyperpolarized, which will lead to formulation of a dipole, leading to generation of a depolarized cell compartments, from which the current will flow into the deeper cortex to the limbic cortex in depressed patients, what we tend to envisage. This is what causes excitability in such patients, and the vice versa happens when you are stimulating the head over with the cathodal electrode there. So this change will only last for a few minutes or seconds unless you are giving it for a longer period of time. For a longer period of time, over successive intervals, it leads to generation of long-term potentiations, which is usually mediated by the glutamate receptors, particularly the NMD and the AMP receptors. And that is what leads to change in the morphological structures of the synaptic connections itself. And that change, when it stabilizes, it leads to generation of newer kind of behavior, newer kind of cognition, newer kinds of emotions. And that is when we say that the patients are getting better with our treatment. In terms of component, it is a simple device, and which has only electrodes, sponge, and some fixators. There are variety of devices which are available in today's time. They primarily have only 4 knobs. One is for changing the amplitude of current. The other is for the entire duration of stimulation, and then for ramping up or ramping down of the current. All these devices, some of these devices are also available commercially, and high-end devices are only seen in research formats. So the one that we use in our department is a StarStream R32, the highest end device, which is a Wi-Fi capable device too. There are a lot of electrode wires which connect such devices to the electrode placement over at the head, and they can utilize different kind of sponges like rectangular or circular formats depending on what kind of machines it is being used upon. We utilize a special kind of electrode system which is called as a PI-STIM, which also has the capability of not just delivering current but also assessing current from the brain, just like an EEG. So that helps in real-time monitoring of what is happening inside the brain when we are trying to simulate things. So when you keep 2 electrodes over at the head, you tie it up with a fixator or a rubber band, and then you can keep stimulating the individual for a certain period of time. You can also utilize a kind of a head cap under which the electrodes can be placed, or like we use a different an array of electrodes to stimulate different regions. You can formulate a whole circuit to do that. This is our facility where it's a simple chair on which the patient can lie, and the technician sits on at the computer system to monitor the entire thing in the software wirelessly. The electrode positioning is what is important there, because we want to stimulate a different area for following the regional neuroanatomy there. And for that, one can use 1020 EEG systems or softwares like Beam F3 or newer kind of stereotactic neuronavigation approaches. The area of stimulation which is important for depression is dorsolateral prefrontal cortex, particularly the dominant side. That is what is being stimulated. In a conventional tDCS system, which only uses an anode and a cathode, in them there are only 2 electrodes over at the head. So they have a bidirectionality of change. The anode will cause excitation under it, and the cathode will cause inhibition under it. And the current will flow from the anode to the cathode. So there will be a diffuse current flow depending upon how far these 2 anode and cathode electrodes are placed. There is an advancement in the system in form of HD tDCS, which is called as high definition tDCS, in which you do not just have only 2 electrode systems, but a multitude of electrode system in which you can format a whole circuit depending upon what you want and what area to stimulate or what circuit to follow. So commonly one uses a single electrode at a center surrounded by a ring of electrodes. So this central electrode is say anode and the ring is of return electrodes, then you are only able to stimulate a particular area and there is no diffusion happening in the brain. So the focality increases for stimulating the brain for excitation or inhibition using these kind of paradigms. The protocols that we use are dependent upon whether we are using a conventional tDCS system or a high definition tDCS system. In conventional, one can utilize the left DLPFC anodal or right DLPFC cathodal stimulation, or you can use the right supraorbital cathodal stimulation. In a high definition tDCS system, the entirety is only focused on one particular area, so that is usually the left DLPFC anodal stimulation. We deliver the current for usually an amplitude of 2 milliamperes for a duration of 20 minutes, and usually we deliver 2 sessions in a day if the patient can afford, and with an intersession interval of 3 hours. And a single cycle of tDCS would require somewhere around 20 sessions for all patients. So this is what we do in the term of technique, and I request Dr. Ankesh to present a case of depression who we treated with tDCS.
Thank you, sir. Good afternoon, everyone. I'll start with the first patient of today's presentation. This patient is a 30-year-old married woman. She's a homemaker by occupation, and she has no history of prior psychoactive substance use, no history of mental illness in her family, and herself has never suffered any mental illness in the past. She was 29 years old when she gradually started to feel sad most of the times of the day. She would feel lethargic. She would get tired easily. She would have to force herself. She would have to force herself to even look after a household chore, to tend to her family, even her daily self-care activities, her personal hygiene. These began to appear to be burdensome to her. She had to make a lot of efforts to look after her own self-care and personal hygiene. She would have difficulty falling asleep at night, and upon waking up in the morning, she would not feel fresh or energetic. She would have instances where she would appear very absent-minded and forgetful to her parents, to her family members, and she would herself say that she's having difficulty concentrating on her tasks. She began to lose interest in interacting with other people. She would prefer to stay confined in her room. She would not enjoy her daily activities. She would not enjoy spending time with her children. She would not enjoy going out for evening walks, interacting with her own friends, watching movies, or listening to music. In view of all of these symptoms, the patient and her family members decided to visit us, as her subjective distress had increased a lot. There was a lot of dysfunction in her in different domains of her life, and her quality of life had begun to deteriorate. She visited us in August 2023. She was evaluated in the OPD, and upon discussion, she was informed that she's suffering from a depressive episode. After discussion, an informed decision was taken to start tDCS as an intervention for her treatment. Prior to initiating tDCS, she also underwent further evaluation of objective measures of her depressive symptoms and anxiety symptoms. There were 2 psychometric instruments for depression and 1 instrument for anxiety. She also underwent cognitive testing, and after that, her tDCS sessions were begun. She underwent 20 sessions of tDCS over the course of the next 10 days, 2 sessions per day. And we can see that at the end of her tDCS sessions, she had significant improvement in her depressive and anxiety symptoms. At 1 month follow-up, the symptoms are very minimal. There was drastic improvement in her functioning and her distress. Her quality of life had also improved drastically. This improvement was sustained even at 6 months of follow-up. And I just want to remind you that she has not been on any kind of medication. This is just tDCS 20 sessions for 10 days, and she had continued to maintain that improvement for the next 6 to 8 months. Now here, I am showing the trajectory of the objective measures of a depressive and anxiety symptoms. We have two instruments for depression, Montgomery-Åsberg Depression Rating Scale and Hamilton Depression Rating Scale. And for anxiety, we have Hamilton Anxiety Rating Scale. These instruments were applied on the patient by two independent raters, not including the treating physician. And they were applied at different time points at baseline, after 10 sessions, after 20 sessions, at first follow-up at 1 month and second follow-up at 6 months. So we can see that drastic improvement in her symptoms and the sustained improvement even after cessation of intervention. These are two graphs which are showing the improvement on her cognitive testing. We have used two tests, trail making and verbal fluency test. Both are one of the most commonly used tools for assessing cognitive ability of individuals, and especially in research for depressed patients. These are very commonly used. Trail making test has two parts, part A and part B. And verbal fluency, we had 4 categories. We can see in trail making, taking lesser amount of time is an indicator of better cognitive abilities and performance. And in verbal fluency test, being able to name more number of items is taken as a as an indicator of better cognitive ability and performance. So we can see that the patient has improved even on the cognitive testing. I would now like to invite Dr. AIIMS to present the second patient.
Thank you, sir, and good evening, good afternoon, everyone. So I'll start with the second case. This was a 25-year-old unmarried male who was a student, and he had no history of substance use in past or any past psychiatric or family history of mental illness. So the patient's illness started at the age of 23 years, where he started having difficulty in falling asleep and later would start feeling sad throughout the day. His interaction with family members over the next few weeks decreased, and he also started having difficulty in studying, where the patient would be unable to call and register all the information that he would be trying to study. The patient also started feeling tired very easily early in the morning. He would also have difficulty in falling asleep and would also have anxious ruminations and psychomotor agitation. These symptoms increased over the months and patients sought consultation for the same. The patient was maintained on psychotropics, which were prescribed by a private psychiatrist, but records for the same were not available. The patient did not have any significant improvement with the treatment, and the patient later followed up in OPD in April 2023. After starting the patient on antidepressants with no significant improvement, a plan for tDCS was made, where the patient received 20 sessions, 2 sessions each day, and the patient also had received objective testing before the initiation of sessions and the cognitive testing as previously described. After the tDCS sessions, there was a significant improvement in his symptoms, but the improvement stalled at around 50%, and at 1 month and at 6 months, the improvement sustained, but the patient did not improve further regarding the same. Although the patient started having improvement in his functioning and he started reading back and continued his studies, but his symptoms persisted and the patient was continued on psychotropics along with this. So coming on to the psychometric scale scores, these 3 scales as previously described are also applied in this patient. And as we can see, the scores on MADRS scale, initial scores were around 43 and there was a significant decrease which was around greater than 50% towards the end of 1 month, and which was sustained at 6 months. Similarly, on the other scales, Hamilton Depression Rating Scale, there was a decrease that there was a significant decrease which was greater than 50% that persisted at 1 month and 6 months. And similarly, there was also a decrease in scores in anxiety rating scales from 21 to 11 at 6 months. On cognitive testing, both trail making aid B and verbal fluency tests were applied, we can see that the total time taken to perform the trail making tests has decreased post tDCS, but the verbal fluency categories did not change significantly, although there was some decline in few categories. With this, I invite Dr. Rohit Verma sir to take it. Thank you.
Thank you, Hemant and Ankesh. So these are the two cases in which one of them had no antidepressant or medications. The other required was more of not entirely treatment resistant because we do not have the entire plethora of what he was getting treated with, but he did show some amount of resistance even with our treatment, which was ongoing in the ROP. And both the patients we were able to see that there was a significant amount of change happening with this new machine. So although this appears a new arrow in our quiver, what does the larger literature says? The larger literature says that amongst all the newer neuromodulation techniques, tDCS does favor a certain amount of efficacy to it and is seemingly effective in major depressive episodes. But nothing can be balanced in science, particularly without assessing its tolerability profile. And in that sense, tDCS shines amongst all the neuromodulatory techniques as of now. It has a very limited profile of side effects, and that is very, very transient in nature. And those who do develop certain amount of problems after tDCS that last only for a few hours or days, and that is highly manageable with treatment too. So in essence, tDCS seems to be a promising approach, not just as a first line of approach in depression, but also for cases who are having treatment-resistant depression there. And future with various to me seems bright. I thank you all and other partners with whom we have been collaborating over the years to conduct research and conduct more work on assessing how this entity is functioning and providing benefit to our patients. Thank you all. Sir.
Rohit, so if there are any questions, we'll take it up. I think.
Right, sir. So at our institute, we have done, we just published one retrospective chart review from past 5 years. Then we have done a double-blind study, triple-blind study, and all of them have favored the tDCS system. International, sir, as I showed, it has a lot of studies have been conducted on tDCS systems, and this was not a very recent one. It was a network meta-analysis, so I just presented it because it compared all the neuromodulatory techniques. The recent one is from 2023, and that also favors active versus sham tDCS over all other measures. Yes, so it's approved for use of treatment-resistant depression in European sector, in Japan, as well as in Australia now. But FDA says that it can be used if there is no other treatment modality which is working out. So not as an FDA approval state, but as an off-label use, tDCS is still being used in the US by many psychiatrists. So that is something which the patient has to take a call on. So we provide choices. What in terms of, as I said, all the three management strategies are provided to the patient in terms of psychotherapy, in terms of medications, or in terms of machines. It's the patient who can choose what pathway they want to go on. We are there to provide the pros and cons of each pathways, or what can provide the best part of benefit.
That there are medicines which are first line, and this is not first line in that sense. But there are people who will say that they want to try it out because it has virtually no side effects. Improvement may occur within 10 days time, and so it works. So it's basically based on patient preference. In that sense.
No, as of now, I'm not aware.
Maintenance is nothing, and there are no side effects. The improvements occur. So the expected thing is that it will be cost effective, but the literature probably is not available as yet.
Fortunately, as I said, the tolerability profile is so great that as of now, there is no contraindication to tDCS system. Absolutely, in that sense. Even unless someone has a plate which is conducive for electricity, unlike titanium, so it can still be used. Rather, we use it for traumatic brain inhibitions.
Patient profile in which we would prefer to use tDCS.
Compared to pharmacotherapy, as I said, like it's a patient's choice. Scenarios like wherein the pharmacotherapy might be much more acting as a devil for the patient, like say pregnant females. The possibility of them having teratogenic effects due to antidepressants would be quite high there. So in those scenarios, if you want to take a chance and the patient is not going for say ECTs or even for TMS, then you can go for tDCS in that scenarios. So we have been doing it for past 8 years. So there are a lot of follow-ups available with us. Some of them.
Effects of tDCS, are there follow-up studies available in the literature?
Maximum period for that is 1 year that we have. Like she was one of those. No further episodes have. But the problem is that depression is a unipolar or a bipolar or a recurrent polar entity. One never knows whether the second episode is going to happen or not. So in that sense, we're still in dark there, but hopefully it has not recurred at least.
The efficacy is not so well established for most treatments, except for a few antidepressants. For most, it's a little.
So science always calls for a defensive stance first. Do no harm is the first motto. And when you say that do no harm, then you are trying to go into the evidence which produces the best benefit without causing any kind of side effects profile to the patient. So as of now, the entire worldwide literature suggests not to go beyond 20 sessions in a single go. There are studies coming up now, particularly in TMS, where there are accelerated sessions, there are longer lasting sessions there happening. But in tDCS, that is a very mild literature for that. So as of now, we are not stepping beyond our boundaries to go towards the extent.
Finished with our time. Dr. Sagar, you want to make any?
We can, but since the patient became functional, from our perspective, one of the scales showed a complete improvement, near complete improvement. At the other scale, there was not that great an improvement, but that scale also takes into account the somatic symptoms, so which could be their possibility in form of a comorbidly coexisting somatoform, undifferentiated somatoform disorder, which could have been hampering the patient. So we didn't follow it.
Everyone for the lively discussion. We hand it over to surgery.